Who's the admin? Yeah, okay.
Yeah. Hello, everyone. Today we'll cover osteogenesis imperfecta. We will talk about why the bone breaks, why it deforms, and how management strategies are employed. Just to begin with, I want to say that we should remember that OI is not just brittle bones, it is a systemic connective tissue disorder with bone fragility, progressive deformity, and extraskeletal issues pertaining to the teeth, hearing, CV junction, and cranial base anomalies. This talk is very practical. We will talk about classification frameworks that is going to help us doing making decisions, some key radiographic findings and stepwise management, a bit about medical therapy and orthopedic strategies. So we will start with seeing that what we are going to learn from this lecture. You will understand a little bit about collagen type 1 and how the defects in that translate to OI problems in OI like fracture, bowing, deformities. We will learn how to use the Sillens classification to prognosticate the illness and communicate regarding the same with the parents. We will recognize classic skeletal and extraskeletal signs and the key radiographic and imaging findings, and then come up with a structured plan which will include a little bit about rehabilitation, bracing, fracture care, deformity correction, and implant choices when it comes to nailing. At the end of this, we will be comfortable explaining why this phenotype is looking the way it does and how our treatment is going to differ from case to case. So, OI is a group of heterogeneous disorders, genetic disorders, most commonly involving the COL1A1 and COL1A2 genes, leading to abnormal type 1 collagen either in quantity or in quality. The phenotype ranges from mild fracture tendency to perinatal lethal forms. And the same umbrella diagnosis can look very different completely depending on what type it is. So the incidence is around 1 per 15,000 to 20,000 live births, but the prevalence varies as per the detection and the genotyping access. So for us, the dominant issues are recurrent fractures, deformity under load, growth impairment, and secondary disability. So to understand the management, we first need to understand type 1 collagen and how these defects behave. So type 1 collagen is the main structural protein of the bone, also of the sclera, dentin, and tendon sheaths. So the phenotype is multisystemic. So this type 1 collagen has a triple helix structure, which has two alpha 1 chains and one alpha 2 chain. And there is glycine at every third residue. Glycine is, that we all remember, I think, is like the smallest amino acid. And that what that does is it helps the helix pack very tightly. And any substitution in this is going to disrupt the stability of the entire construct. So to translate clinically, we can say that if we have less collagen, the bone is going to be underbuilt and will lead to fragility. And if we have abnormal collagen, the bone matrix is going to have poor quality, which will lead to fragility, deformity, and have more severe phenotypes. So, with this basis, we will go ahead and see what is the difference between a quantitative and a qualitative problem with this collagen. So, on the left hand side, you can see that there are this is a representation of how the normal collagen is. So there are two pro alpha 1 chains encoded by COL1A1 on chromosome 17 and one pro alpha 2 chain which is there on chromosome 7. And then they help and form this collagen triple helix with this glycine cross links. So this is how normal collagen is formed. But now let us focus on this figure B. This shows what a quantitative defect does. So this is essentially Sillens type 1 OI, where you have like a stop codon in one of the COL1A1 genes, which will result that this will not form any mRNA. So the total number of collagen, the molecules that are formed are going to be less in number, but normal in structure. So like this is a quantitative error. And then talking about this type C figure, this is formation of a mutant type of collagen. When you this there is a mutant collagen and they're missing, the glycine crosslinks are going to be missing. So the structure that will be formed in the end will not be normal and will be a mutant. And that is why phenotypes are going to be more severe, and generally they translate to type 2, 3, 4 of OI. So we group them on the basis of this quantitative and qualitative issues because they are what are going to predict the severity of the disease. So quantitative defects are also called haploinsufficiencies. About half the amount of normal collagen is present, and qualitative defects are where abnormal collagen chains get incorporated and they comprise the whole triple helix matrix, and therefore the phenotypic representation is going to be much more severe. So to put it very simply, it is like quantitative defects. The child is going to have fewer fractures, better remodeling, and less progressive deformity. Whereas there is involvement of quality, there is going to be more deformities, growth issues, sometimes vertebral compression, and long bone bowing as well. We should just remember here that not all OI is related to COL1 gene. Sometimes there can be errors in processing, mineralization, osteoblastic functions, which create typical atypical phenotypes like the type 5 or even high bone mass forming. So now that we have understood this whole mechanism, we can talk about classification also, because classification is basically a mechanism plus severity. So this classification that we follow has been given way back in 1978 called the Sillens classification. It is the classical clinical framework. It includes type 1 to 4, which have later been expanded, which I'll talk about as well. Just to give a quick mental model of what this is, type 1 is a mild, non deforming type where you see blue sclera commonly. Type 2 is perinatal, lethal. And type 3 is severe, progressively deforming. Survival is there beyond neonatal period. And type 4 is moderate with variable sclera and it is one of the deforming types. And now I'll talk about the modified Sillens classification. Cole has recommended modification of the original classification, wherein he did an extensive review of in 200 patients with OI of the genes, and he discovered some non-collagen gene defects which were causing OI with histological features dissimilar to those of conventional types, and that led to the addition of types 5 to type 11 to this nosology of OI. So, type 5 has autosomal dominant transmission, whereas type 6 to 11 have recessive transmission. And these types from 5 to 11, they constitute for about only 5% of the total cases of the OI. So this modified Sillens adds additional clinical types, especially 5. Type 5 is very distinctive because of its hypoplastic callus, metaphyseal dense bands, and high frequency of radial head issues. We'll see these X-rays and everything in the lecture as we progress, but this is like one type of OI that we should not miss. There's one more group classification that is being given by the International Society of Skeletal Dysplasia, wherein they have placed OI into broader skeletal dysplasia nosology. So this captures, genetic heterogeneity, dominant and recessive forms, collagen producing defects. They have grouped them on the basis of the severity, the common variable with normal sclera, progressively deforming and progressively non-deforming types, and perinatally lethal types. This is essentially the same types of OI seen in Sillens, but this is given by the Society of Skeletal Dysplasias, and this can be used for better communication interdepartmentally. So OI is a connective tissue disorder. So we'll go ahead with the clinical features now. Is a connective tissue disorder, and that's why the extraskeletal findings are often the first clue that we see in the patient. So starting with maybe the thin collagenous sclera is going to allow the choroid to shine through, resulting in blue colored sclera, which is typically seen in type 1, but is not universally seen in all types of OI, as we have seen. Triangular facies can occur, which are helpful in pattern recognition. Hearing loss is there often later in the age group, might be conductive, sensory, neural, or mixed type. Therefore, it is important for us to counsel the families regarding long-term surveillance. Then dentinogenesis imperfecta, wherein there is abnormal dentin formation leading to the formation of opalescent teeth, fragility, risk of caries, and primary teeth being affected is more common. And then they tend to have bleeding tendencies, so they bruise very easily, which can show collagen fragility. And there is a risk of perioperative bleeding as well if we are planning any surgical procedure for them. So we have to keep that in mind as well. They generally have hypermetabolism or heat intolerance. So this is a very important anesthetic risk because we have to really counsel the patient, and the anesthetist has to counsel the patient rather about the risk of malignant hypothermia in these patients. And even cardiac, we have to screen them cardiac wise also because they are known to have mitral valve prolapse, aortic regurgitation, less commonly, but they are clinically relevant. So one of the key extraskeletal feature in these children is dentinogenesis. So maybe this is how it looks clinically. You can note the opalescent brown discoloration and the characteristic fragile appearance. We should know that this is not just a cosmetic issue. The teeth are structurally weaker, prone to wear and cavities. That is why that is going to impact the nutrition and the quality of life as well. It is also a clue on as to how severe the disease is because it will help us differentiate from other causes of the low bone mineral density. Early pediatric dental involvement, preventative care, and anticipation for dental work has to be put in the minds of the parents as well. So now we'll go and discuss about orthopedic manifestations, the ones that generally we get called in for. So beginning with bone fragility and fractures, which is often the first presentation, progressive deformity and bowing after the child having repeated fractures, ligamentous laxity, short stature, deformity of the spine in terms of maybe a scoliosis or kyphosis or a combination of both, or vertebral compression. They sometimes have vermian bones also. There's a possibility of basilar invagination, symptoms later in life, invagination, impression. We'll see about all of those things as well. And there's a very classical fracture type or fracture pattern which is seen in children with milder types of OI, which is a olecranon epiphyseal avulsion fracture, which is sometimes seen as like the most common presenting sign. They can have coxa vara also, causing them to walk with a limp. They can have congenital anterolateral radial head dislocations also. So these are the things which are going to show up on the imaging as well. So we will go ahead and look at some of these images of the x-rays. So this is one patient clinical images of a child with severe deformities of both the lower limbs alongside the radiographic appearance showing severely bored femur and tibia and with the popcorn calcification. We will see what that is. I've put up better x-rays as well. So I'll start with vermian bones. These are intrasutural accessory bones, giving the appearance of a puzzle piece. So they are detached portions of the primary ossification centers of the adjacent membrane bones. For them to be significant, they should be more than 10 in number and measure at least 6 by 4 mm and have to be arranged in a general mosaic pattern. But these vermian bones can be present in other type of bone dysplasias as well. For example, cleidocranial dysplasia, congenital hypothyroidism, pachydermoperiostosis, Menkes syndrome, and some other types of trisomies. So their presence is not really pathognomic for OI. They are not very specific to OI, but they are very strongly supportive when they are combined with features like maybe osteopenia, long bone fragility, blue sclera, or dentinogenesis imperfecta. And it is kind of helpful in infants where you don't have those long bone findings which may be very subtle, or maybe in type 1s. So if vermian bones are present with the fractures with osteopenia, we should strengthen our suspicion and maybe support these all findings support the need for a genetic confirmation as well. So now let us look at this is one of the x-rays where you can see the vermian bones. Now, let us look at what popcorn calcification is. We look at the irregular metaphyseal, epiphyseal calcification. These were first described by Goldman and co-workers, which described them as these popcorn calcifications in the metaphyseal and epiphyseal areas of long bones, very close to the growth plate. They appear as clustered collections of rounded or scallop radiolucencies, and they have a sclerotic margin. They are seen more frequently in the lower limb than they are in the upper limb, and their appearance is going to parallel with the development of the growth plate, and whenever there's a growth spurt they do increase in number also, and they are often associated with more severe forms of OI, and they are going to cause more growth disturbance and more deformities and cause more morbidity. But this is not one of the primary drivers of morbidity also. One of the major drivers of long-term morbidity in these patients is the spine issues. The spine can show a marked osteoporosis, vertebral bodies are compressed, they become biconcave with bulging discs, scoliosis and kyphosis develop, Eventually, in more severe forms of OI, we have to look for vertebral compression, biconcavity, kyphoscoliosis. This because spinal deformity is going to impact pulmonary function, sitting balance, cause fatigue and pain, maybe neurological involvement as well. So spine deformity can progress even if the fractures are controlled. So the surveillance in spine has to be proactive and not reactive. So there are certain cervical spine anomalies as well which occur in these patients that I've discussed in the management, because we'll discuss it there. So when it comes to diagnosis and workup, most of these cases, clinical examination, radiographic pattern, family history can lead to a strong suspicion, can then be confirmed by genetics. So there are certain examination findings which are to be looked for with utmost care, beginning with the history of fracture, like age at the first fracture, frequency and mechanism of the injury, growth and height trajectory, deformity pattern and mobility level, pain and function, how are the teeth, how is the hearing, if they have any respiratory symptoms, any spine symptoms, any symptoms of CVJ anomalies like maybe headaches, neurological signs, UMN signs, and then imaging, we have to get full length bone x-rays of the film if we are going to plan a surgery, DEXA if we are doing tracking of the BMD, cervical spine if it is indicated. Labs are usually normal with normal calcium, normal phosphate. If ALP is if there is abnormalities with the alkaline phosphatase, we have to rule out mimics like hypophosphatasia. And getting a genetic testing done is going to confirm the diagnosis, help us counsel the parents, and sometimes rule out NAI, but that is not typically the reason why we do a genetic testing. Because of these multiple fractures in different stages of healing, there might be a chance that we need to get it done to rule out any chances of non-accidental injury that the child is being subjected to. That is why documentation of it is important. So, and OI is one of the more commonly diagnosed skeletal dysplasias on fetal ultrasound. So, on some clues on the ultrasound are maybe the type 2 ones are seen properly, and they generally don't have any family history also. The long bone deformity is going to be there, that implies fractures. The length of the femur is going to be reduced. The skull is going to be echogenic. And there are mid trimester scans which you can see these couple of things where you can have like a red flag signs which can tell us that maybe this is OI. Like the length of the femur is less than fifth percentile. This is all a radiologist is going to tell us. Maybe the cranium, chest circumference, mandible, clavicle, scapula are smaller in size. They have mineralization defects. They have deformities, disproportion in the sizes of the skeleton versus the head and the abdomen. So these findings are maybe variable in types 1, 3, 4. Type 1 is more or less going to look normal. But after you get a detection of type 2, the recurrence risk is around 2 to 7% because of parental mosaicism. So counseling is very, very important. And if indicated, early diagnosis via chorionic venous sampling is done around 13 to 14 weeks of gestation. So these are all very severe forms of OI. So what happens when you get these very milder forms of OI and when the phenotype is not very dramatic? So that times what happens is they are going to have very thin cortices on the X-ray. The frequency of fractures is going to vary. You could see fractures in multiple stages of healing. There might, in less severe forms, remodeling is there. Maybe not acceptable, but it is there. Is insufficient, and the deformity is going to accumulate. And often these micro fractures or stress fractures can create asymmetric limb alignment. Like one limb could go into valgus, the other could go into varus. Um, and other types of OI, like type 5 OI, which I was speaking about, has very special radiographic clues, and we should not be missing them. They have, like these hypertrophic callus at the fracture sites, and post-traumatic swelling can be very, very dramatic. There can be radiodense metaphyseal bands near the growth plate. They have more propensity towards radial head subluxations. Palatal coxa vara could be there. Protrusio acetabuli could be there. There could be a patellar radial head or a hip dislocation. Platyspondyly, biconcave vertebra can also be present. So these are the images of the hypertrophic callus seen at the fracture sites. The radiodense metaphyseal bands, the subluxation, anterior subluxation of the radial head, gradual subluxation of the radial head as seen in these images. Um, Yeah. So now let's talk about maybe what laboratory findings are there. I've already told that more or less everything is going to be within the normal limits, like the calcium and the phosphorus. But ALP could be elevated during active fracture healing as well. So we have to keep that into context when we are looking at the labs as well. So if the labs are atypical, very low ALP is there, maybe there are mimics like hypophosphatasia, and genetic testing is increasingly matlab, accessible, and then we can help confirm the diagnosis. So once we've had our clinical examination, we had our radiology, we had our labs, now we can like move on to management, starting with our multidisciplinary goals. Our goals have to be to reduce the fracture burden and pain, maximize the function, and preserve growth and mobility of the child. We have to prevent or correct deformity, but protect the growth plates and minimize surgical morbidity. We have to follow like a multidisciplinary approach where we work with the endocrine metabolic team, with the rehabilitation and physiotherapy team, the dental team, audiology, pulmonology, genetics, and anesthesia. We need to teach the parents about safe handling strategies. We have to manage their school and their activities. We have to give the parents realistic mobility expectations and how the transition to adult care is going to be. We don't have a definitive cure for this disease yet, but there are some disease modifying attempts that are being done, but there is no definitive cure. No therapy currently corrects the underlying gene defect in routine clinical practice. There have been instances where they have tried these three papers which I have put down. Maybe if is anyone interested, they could go and see. They have used allogenic bone marrow transplantation and mesenchymal stromal cells, but they had early improvements in the first 6 months, and later they had some problems with the osteogenic potential. So nothing was viable, and they have not found any cure yet. So historically, medically, this is being managed. They have tried a lot of agents. They did tried hormonal therapy, sodium fluoride, calcitonin, calcium supplementation, growth hormones. These are largely not the mainstays of treatment now, and the modern standard of care is bisphosphonates and newer agents in very special cases. So bisphosphonates are the cornerstone therapy. They reduce the osteoclast mediated resorption. They help improve the BMD and vertebral morphology as well. So indications vary across centers. However, administration is guided by frequent fractures, significant pain, low BMD, vertebral compression, and functional decline of the child. At the outset, it is very important to counsel the family and set expectations to optimize patient expectations. We should ensure normal calcium, phosphate, and vitamin D. And you can get a dietary consult done as well to ensure adherence of the child and the family towards this regimen. So there are certain regimens which are done. Pamidronate was the one that was done. It is like IV cycles are given over 3 days and repeated every 4 to 6 months with a dose of zero point 0.5 to 1 mg per kg per dose. They helped in reducing bone pain and increasing the BMD. Oral agents have also been given like alendronate, but these days zoledronic acid has gained popularity because it is the most potent, and it is logically simpler, shorter infusion, and you can wait for longer intervals. Like for a child less than 3 years, 0.025 mg per kg per dose is given. More than 3 years, 0.05 mg per kg per dose infused over 1 whole hour, and then you don't give it for another 6 months. So six monthly you could give this. There are some studies which have seen the efficacy of oral versus IV, and they have reported similar outcomes. So it is like institution based policy. Whatever is followed can be done, but literature suggests that there is not a lot of difference. These papers which I have put are have concluded these outcomes. So these are these metaphyseal dense bands which are seen called as zebra lines or Salter lines, which are seen as a normal radiographic effect of cyclical therapy of bisphosphonates, which are parallel to the growth plate. So there are certain adverse effects of bisphosphonates which are observed. There is a risk of hypocalcemia, if especially when there's a deficiency of vitamin D. Acute phase reaction, including seizures, which are often related to electrolyte imbalances, renal issues. Therefore, hydration is very important when we are administering these bisphosphonates. There's a concern regarding the osteonecrosis of the jaw, which has been reported essentially in adults. It is extremely rare in children, which is there is nothing has been reported till date, but still we have to get regular dental checkups done for the children who do receive bisphosphonates regularly. I would like to just mention two drugs here. One is denosumab, and one is like anti-sclerostin therapy. Denosumab is a monoclonal antibody which reduces and osteoclast formation. It requires careful monitoring because it can cause rebound phenomena and cause disruption in the calcium homeostasis. And this very new drug, which is a humanized mice monoclonal antibody, it is currently approved only for menopausal, postmenopausal osteoporosis. However, there are some trials which are going on for OI, but they have not come out with any what do you say results yet. But these are something which this is something where there's work going on. But we should always remember that any kind of medical therapy is going to only improve the bone biology. But orthopedic management is the one that is going to prevent disability. So maybe we should just shift focus to orthopedic treatment in OI. So our aim has to be maximize independence and mobility while minimizing fracture-driven morbidity. I will cover orthosis, rehab, safe handling practices, fracture management principles, long bone deformity correction, implant choices, and a bit about spine deformity and cranial base surveillance. So I'll first start with rehab and orthosis because immobilization for prolonged periods of time is going to worsen the osteopenia. So, if the neonate survives the neonatal period, supportive handling is the key, and there are many birth fractures which stabilize very quickly. We have to avoid any kind of prolonged immobilization at any age in these children because it is going to worsen the osteopenia and stiffness and increases risk of future fractures. We have to use very minimal, gentle splints for comfort and stability. We have to think in terms of weeks and not months. In very severe forms of OI, splinting is not preventative, it is very foundational. For severe lower limb involvement, lightweight HKFOs can enable standing and walking with walker or crutches and can reduce the risk of fractures. Now, talking about mobility aids, motorized wheelchairs are often ideal because many of these children have normal cognition to use them, but they lack the upper limb strength for manual propulsion. But I do know that in the Indian setting, uh, maybe this is not the choice for a majority of the patients that we see day in and day out. Now, talking about management of long bone fractures, do we manage them any differently than typical pediatric fractures? The core principles do remain the same. The fractures usually heal, but the recurrence is common. If you have to immobilize only till the symptoms settle, you have to give very minimal form of immobilization for comfort, and we have to encourage early return to safe activity to avoid deconditioning of the child to loading. So radiographs are not always necessary for minor stable injuries. We have to treat them clinically if pain strongly suggests a fracture, even if the X-ray is negative initially. So families often become very skilled at this symptom-based management and support. We have to support the family and we have to document everything properly, and we have to just tell them that you have to be careful with them for a while. For newborns, a short period of gentle splinting for 1 to 2 weeks. If unstable or handling is difficult, you could do that. For a older child, we have to treat appropriately based on the fracture type and pattern with closed reduction, casting, with percutaneous spinning, internal fixation whenever necessary. We have to be certain and careful that we handle the child with care to avoid any iatrogenic fractures. And we have to always consider any type of intramedullary fixation, whether it's a fracture of the femur or the tibia or the radius ulna. We have to always consider doing an intramedullary fixation over plates because plates are going to cause stress risers, which are going to cause fractures. The fractures lead to deformity, and then deformity is going to lead to more fractures. So, deformity management is going to become preventive surgery for these kids. So, management of deformities, the fragility and the muscle forces with the repeated fractures are going to cause bowing. This bowing shifts the mechanical axis. It increases the risk of fracture and will cause more bowing. So, this is like a vicious cycle which the child goes in this cycle for about a very long time till he undergoes a definitive procedure where he gets the deformity corrected. So, main surgical indications are recurrent fractures due to this deformity and the deformity preventing bracing or impairing function of the child. Correcting deformity is going to help the mechanics, but long term ambulation is going to be dependent on the overall severity, endurance, rehab, and the status of the spine, and not just straight bones. So the options range from minimally invasive to open rodding. You have to choose based on the size, age, fragility, and medical stability. So the options available and described in literature are closed osteoclasis without fixation, closed osteoclasis with percutaneous IM splinting, open osteotomy and intramedullary fixation, the Sofield Miller fragmentation and rodding. We'll discuss each option in detail. So, closed osteoclasis is generally done in very medically fragile children where blood loss and physiologic stress of open surgery is very high. And when these deformities cause caregiving difficulties and other methods are not feasible, that is when you do closed osteoclasis and put them in a cast till it is united under anesthesia or sedation. Gentle manual correction is done, and then a cast is applied till union. As there are no splints, internal splints that are used in the form of implants, the recurrence of this deformity and fractures remains likely. That is why we have to transition them to a brace after removal of the cast. So, closed osteoclasis and percutaneous intramedullary splinting is like while we correct the deformity externally, we could pass a smooth rod, which is like a K wire or a rush nail or a slim nail, percutaneously as an internal splint. It is indicated when repeated fractures interfere with child care and the child is too small or fragile for formal open rodding. So this is technically difficult and fluoroscopy is essential for all of this. And there is a risk of joint penetration, migration, inadequate stability and refracture around the joint ends. So that is why what happens as a result, many centers, stabilize all of these fractures which these kids have or these deformities conservatively for a long time until the child's bone size and physiology allows formal osteotomy and nailing. So coming to open osteotomy and intramedullary fixation, um, we go ahead with this when the deformity affects orthosis fitting and function of the child and the recurrent fractures driven by deformity in the lower limbs and the child is now big enough to undergo this surgical procedure. Herein we do multiple osteotomies to straighten the long bone. Intramedullary, we do long-term internal splinting. Implant choices vary from fixed rods to telescopic rods, but the world has moved away from fixed rods now. We have gone towards our telescoping rods. And this is here you can see this is a black and white photo, but here you can see multiple osteotomy sites along the deformity, and each segment is straightened and it's threaded onto the rod. The goal is to attain a straight mechanical axis with a durable internal splint. Here we have to plan really well for our blood loss, and you have to consider staging the procedure if we are doing multiple segments at a time. And they are going to have poor rotational control, so you need post-operatively a cast and all has to be applied. There are some tips and tricks which are not to be forgotten during the procedure. We have to do gentle handling to avoid iatrogenic fractures during transfers and positioning. We have to watch for temperature rise, maintain cooling strategies. Anesthesia should monitor for metabolic issues as well. Bruising, bleeding can occur. We have to anticipate that they will need maybe multiple transfusions and staging of the procedures if and we to prevent life-threatening hemorrhage. We have to have all implant sizes available, all types of cutters, pliers, saws ready. Fluoroscopy has to be readily available during this procedure. So post-op strategy also matters. Immobilization versus early mobilization, and that's a thin, fine balance that has to be tailored patient to patient basis. As I have already told that rotational stability is going to be poor. So, we need to put them in a cast like a spica or a long leg cast initially. And then we have to encourage early safe weight bearing once everything is stable to avoid prolonged immobilization that is going to eventually worsen the osteopenia and then shift eventually to a HKFO when union is evident and to protect during mobilization. So now I'll talk about rods, the types of intramedullary rods that are used. Fixed rods are limited in growing children, so telescopy rods were developed. fixed rod becomes relatively short as the child grows, and that is why the end of the rods are going to become as stress risers. They will refracture there and they will need repeat surgery. That is why they came up with telescoping rods is the solution for this problem of revision surgeries. So we started with the Bailey to Wow type of rod, then a Sheffield rod, then a Fascia Duval rod that we use right now. They are best suited when there's meaningful growth remaining. Like they are often you recommended, the literature recommends that somewhere around the age of maybe 10 years is when these implants are, used more. So let us now understand how telescoping rods work mechanically, starting with the classic Bailey-Dubov concept. This is a two-part telescoping design where you have, like an outer sleeve and an inner obturator, which is anchored to the epiphysis, so it lengthens with growth. So these rods are, however, no longer available for clinical use, and I've just mentioned them from an historical point of view. We do use the FD rod now. Um, Here in this image, you can see that there's a preoperative lateral X-ray on A image, and B and C, you can see immediate post-operative X-rays. They have done multiple osteotomies. They've straightened the bone in both AP and lateral planes. And the last X-ray is taken at 2 years follow-up, where you can see that the nail has also expanded, and there is no recurrence of deformity or any evidence of peri-implant fracture anywhere because of the concept of the telescopy. So now these are the modern telescoping rods or the fascia to wall rods. The key advantages of this implant was, you could use a single entry approach. They have threaded epiphyseal fixation, which is going to help with the anchorage. They have minimally invasive placement, and you can put really small incisions in most of these cases and insert these rods. But it is really technically demanding. There is a risk of migration. Maybe they don't telescope so well. Maybe they can protrude into the joint also sometimes if there's a issue with the positioning or something like that. This X-ray that you can see is of a 6-year-old girl with OR, was treated with an FT rod. Then she had a fall and had acute bending of the male counterpart. Then the FT rod was placed 4 years prior to this fall. In the figure B, you can see that she underwent revision of the FD rod with a larger diameter rod and a longer threaded distal portion of the male counterpart. In the image C, you can see that it has migrated distally, distal migration of the threaded part of the female, and proximal migration also till the GT was seen. And in the image D, she underwent a revision of the female component only. And in the final follow-up, you can see that the rod has telescoped really well, and this is follow-up from 6 years to 12 years. So this last X-ray was taken at 12 years of age. So now FD rods are going to improve the function and reduce the fracture burden, but there are complications and revisions which occur as the child grows. The key complications I've already mentioned is like maybe there's a proximal rod migration, there's limited telescoping, they could refracture at the junctions. Maybe there is joint intrusion. Maybe if we've done osteotomies, they could have maybe a problem of delayed union or a non-union. So we need to really counsel and talk to the families and explain to them that all of these issues with the growing rods can occur. And this is like a long term pathway, and it is not like we've done once and this surgery is done. So we have to counsel them that this is like a gateway, and we have to keep them under constant follow up, and maybe they will need multiple procedures later also. So we have to optimize the bone health with bisphosphonates, do a good rehab, and we have to do careful surveillance radiographically of the child to extend the life of the implant after surgery. There are some papers which talk about upper limb nailing as well for the humerus deformities. For very severe deformities, they have been done, but they needed multiple revisions after the surgery also. But they had some improvement in function in terms of self care and mobility. So that is a call that you have to take and discuss with the patient whether that is something that they would desire. So practical takeaway are like कि telescoping rods are more complex to do than your fixed rods. They have certain advantages that we have seen, and they do have certain disadvantages as well. That is why our success is going to depend heavily on planning, technique, and follow up, and how the patients and the parent comply with whatever instructions that have been given, and how diligent they are with the therapy. So this is one type of classic fracture pattern that I've spoken about already. This is like the traction apophyseal avulsion of the olecranon. So this is typically seen in type 1 OIs. So here management is simple, like how we do is like a tension band wiring, which is going to restore the functional well, and handle the bone quality gently, and doesn't do any fragmentation also. So, if we get a child with a adolescent patient with a olecranon apophyseal avulsion fracture like this, he or she could be having an underlying OI which has not been diagnosed previously. So we should really go back and look whether he has or she has blue sclera, has any history of DI, or maybe there's a family history, or maybe that could be like a pointer that we diagnose OI in late adolescence or early adolescent age group. So I had spoken about the spine earlier, that I would elaborate a little bit more on these cranial base and abnormalities. Three entities exist which can occur either alone or together, which is the first image on the top is basilar invagination. Here you see that the tip of the dens here, which is marked in the black color, is protruding into the foramen magnum, which is drawn, and the macrade line is drawn there. The image in this middle is showing basilar impression. That is, the tip of the dens is located at an abnormally higher position, but it is not protruding into the foramen magnum. And the image on the bottom right is platybasia, which is the anterior cranial base angle, which is the nasion tuberculum sella, and the basion angle is flat. Okay, and these three, I'm so sorry. Huh. So the incidence of basilar invagination is maybe 13%, impression is 15, and platybasia is 29. But if any of these are present, the possibility that they will have more than one condition together is more than 44%. So if you see any one of these conditions, we have to be very certain that this patient needs more investigations, and we have to look at them more carefully. This is most likely due to the softening of the bone and deformity at the CV junction. There's going to be upward translocation, and that can compress the brainstem and disrupt the CSF flow, which can lead to hydrocephalus. So the red flags that we have to look for when we examine a patient are maybe they're complaining of headache, some facial numbness or spasm, dysphagia, dysarthria, respiratory compromise. Some long track signs might be there, like maybe limb weakness, gait disturbance, some UMN signs. If any of these symptoms exist, we cannot rely only on plain radiographs, and we need to get MRI done. Plain radiographs can be challenging due to landmarks and measurement variability. MRI of the brainstem and upper cervical spine has to be done to assess the compression and the neural effect. Treatment is, if the child is symptomatic, operative indications are warranted. Posterior decompression alone can give a short term relief, but definitive management is going to require decompression and stabilization, often in the form of a OC fusion. Sometimes we could do a stage procedures. So there is this 21-year-old retrospective review of 20 patients, wherein they have studied, they found that 60% of them had a long-term good benefit, 25% had a recurrence, and 15% showed no improvement at all. So, and they could also have thoracolumbar kyphosis or scoliosis, along with CVJ issues. They are more commoner than the CVJ issues. They are more commonly seen, and they are more likely to progress if they are seen in kids who have severe phenotype of OI, maybe type 3, type 4, early onset of the deformity. On radiographs, maybe they have biconcave vertebra, codfish vertebrae, maybe they have vertebral compression, and they have delayed sitting milestones also, which is going to correlate with the deformity. So bisphosphonates that we administer are going to improve the BMD and the morphology of the vertebra, but they are not going to prevent very reliably the progression of the scoliosis. We have to get baseline AP and lateral x-rays done whenever feasible. Otherwise, we could do seated or supine if we are not able to get standing x-rays. We have to document and measure the Cobb's angle in the sagittal profile and the coronal profile. We may look for the pelvic obliquity and the shape of the vertebrae. We have to get CVJ screening done before we do any intervention of the spine. We have to assess the occiput C1, C2. If any symptoms or planned this if they have any symptoms, or if they are planned for any major correction in the dorsal or lumbar spine, you maybe get a CT MRI of the whole spine also. And you evaluate them pulmonary wise also, or you have to track the PFT, and you have to see whether they are entering that curve of restrictive lung disease as the curve's progressing, because that is one of the surgical indications. Radiographic monitoring is to be done every 6 to 12 months during growth. And if you can if you're able to document rapid progression, or maybe there's increase in pain, or any decrease in the function, we can do more frequent x-rays. So non-operative care is primarily for comfort, posture, sitting balance, fatigue reduction, and mobility support. They are not going to provide a lot of curve control in these patients of OI. Some exercises for core and paraspinal strengthening within safe limits. Endurance training, posture training is encouraged. Maybe custom wheelchairs can be provided for them. Bracing is often going to fail to halt the progression due to fragile ribs, poor force transmission, and intolerance to the brace, but it can still support function and provide some sort of comfort to the patient. So the question is that when do we offer surgery for these patients? The typical threshold for offering surgical intervention is when the curves are progressive with a degree of 45 to 50, with a lot of growth remaining, causing some functional compromise or pulmonary impact. Or if it is a very severe type of OI, we can consider for early intervention even below 40 degrees if the progression is rapid, because the surgery later on is going to become harder and riskier. So you have to escalate our surgical indications sooner if there's rapid progression. There is a lot of significant kyphosis or sagittal decompensation. There is declining PFT, and the curve is causing major sitting imbalance, pain, or any loss of function or ADLs of the patient. So for planning wise, we need to get a 3D CT for pedicle anatomy. Pedicles could be small. The vertebrae could be osteoporotic. We have to optimize the bone health before the surgery. We have to plan the anesthesia well, and or even the blood part, the blood management part. So fusion wise, we have to fuse the entire extent of the curve to avoid progression outside of the construct. Fixation strategies, we have to pedicle screws wherever feasible. We have to do we need to maybe augment the pedicle screws if purchase is poor. Maybe our sublaminars, wires, or bands could share the load. Some centers have also published about using cement augmented screws in select cases. And whether or not to include the pelvis in the fixation depends on the ambulatory status of the child, the distal fixation quality, or the pelvic obliquity, or and if there are any issues with the L5 vertebra in terms of maybe a listhesis or a past defect. This is an X-ray of preoperatively of OI patients with very serious scoliosis, showing 68 degrees right thoracic curve and a 48 degrees left thoracolumbar scoliosis. Postoperative X-ray taken at 20 months post-surgery is showing a lot of correction in the angles. And this image is also taken, I think it's a very old type of implant. Um, what the name? Okay. Um, so this is also done to prevent the progression of the scoliosis, because they are going to, and we have to counsel the parents also really properly that there can be a higher rate of complications in these patients as compared to idiopathic scoliosis. So take home messages are mechanism of why the OI is happening is very important, whether it's a qualitative or a quantitative problem. We have to always remember our classification to counsel the patient and to prognosticate the disease to the patient, to the parents. Medical therapy is going to improve density and the incidence of pain, but eventually we need orthopedic procedures to correct the biomechanics to reduce the recurrence of deformities. Intramedullary nailing is preventative as much as corrective. We have to aim for end-to-end support throughout the growth, and we have to always watch for cranial base symptoms and hyperplastic callus so that we don't miss any type of OI. And OI is about, a longitudinal care pathway, and it is not about only isolated episodes of fractures. These are my references.
Excellent. Very good. Just a few technical points I would like to mention over here. So, a few years ago, you might be aware that, Canada somehow, some centers in Canada, I think Montreal, uh, they have a lot of research, and Fassier is actually from that institute. So they had come down for one of the POSICONs, a few years ago. And one thing about the nail that they mentioned is that when we tend to put our nail as snug as possible. It should be a press fit nail. But they advise against doing that. They said that your nail should be, loose within the medullary canal, because putting it too snug a nail, right, it results in stress, shielding, and results in, almost, resorption of some of the cortex. So, how much reeve your canal, your nail should be at least 1 millimeter less than that. So that is one point. Another thing is, you didn't mention about, Coxa. Did you? Uh, Coxa only
No,
mentioned
I
here.
didn't mention about
Yeah. So,
treatment नहीं किया, but
uh, Fassier again has a very interesting technique. First of all, Coxa, when you see a decreased neck shaft angle, it can be either a true varus or it can be a pseudo varus. And pseudo varus
Hmm.
can be because there is a subtrochanteric non-union with flexion of the proximal fragment. So the proximal fragment is flexed anteriorly, and therefore on the AP view, it appears to you like it is a pseudo virus. So what they recommend is, in such cases, what is to be done is do an AP X-ray with the child placed at the edge of the table and the hip extended as much as possible. So, if it is, so your limb should be beyond the edge of the table, and the hip should be extended as much as possible, so that proximal fragment, it is viewed in true AP profile, and then we can come to know whether it's a really true Coxa or a pseudo virus. Now, if it is a pseudo virus, there is no problem. You can do the osteotomy at the subtrochanteric level and in that flexion deformity, and you can nail it. But if there is a true Coxa then you will have to do something known as the Wagner's osteotomy, where you correct that virus, and at the same time, if there is a bowing lower down, you correct those with separate osteotomies as well. So there is a technique which they have described for that, which it will be difficult for me to describe just uh, over here. But I would recommend that you go back and read this paper again by Fassier on treatment of simultaneous Coxa and bowing deformities of the shaft. So that is there. Then, in the recent years,
Yes.
I think there have been some publications regarding, use of nail with plate. So, the nail is there, but additionally, you add a derotation plate, and you span the whole extent of the hole. Okay, so it should, and the screws should be significantly staggered. It should not be too stiff a plate. Okay, otherwise, that again can lead to significant stress rising. So nail with plate is one more addition that has come about in the last few years. Uh, then you didn't mention about stopping of the bisphosphonate. So any recommendations on that as to how much before the osteotomy you should stop the bisphosphonate, or around the surgery, how long you should avoid bisphosphonate infusion?
So that they have recommended that you need not stop.
Okay.
There does not have to be a break in the therapy or the regimen if you are planning to operate, because the whole concept that it is going to cause delayed union, non-union, they have found that it doesn't really have a significant difference. So the current recommendation is to not have any window or a break or a holiday between correction, deformity correction surgery and administration of bisphosphonates.
So that again seems to be a bit of a controversy. It is not very, we are saying that these are the recent recommendations, but the Canadian group, they recommended that perioperatively for 3 months you should not use injectable bisphosphonate. So that is it. And one specific site which can give a lot of trouble is a distal uterus. So did you come across any, literature on that?
Distal humerus.
Yeah. So now this is one side where we tend to, just treat it pretty casually with
Mm.
treat it with just a cast or something like that. And this has been for some reason distal humerus is a site which has been there are quite a few case reports where the distal humerus goes into pseudoarthrosis, where it becomes almost like a flail elbow. Why that happens specifically at that site is not really known. But therefore, in the recent years, I think there was an article from Korea, I think Choi or so, and published that, where they recommended, fixing distal humerus with bipillar plates with something that they called as a sandwich bone graft. So they recommend that, these fractures should not be taken very lightly. Benjamin Joseph also has a case report, has a publication on that. And so it should be treated very aggressively with, with fixation, though in smaller children, we do tend to treat, distal humerus fractures, distal third humerus shaft fractures. But in osteogenesis imperfecta, for some reason, that site has been notorious to go into a pseudoarthrosis and really a flail segment though. So that is one. Lucky, I think you did a very good job.
Yeah, very
So,
good, Sanika.
Hari, you're there? Oh,
Yeah, I was listening. I couldn't resist. I was just lying down and listening. We've had years back non-union, but that time there was no talk of any bisphosphonates or nothing. It was just a really small atrophic non-union of the
yeah, atrophic
distal
nodules.
humerus bilateral, and we did a mother's fibula grafting,
Oh.
which did succeed to some extent. I think myself and Kailash even have a Kailash Devalia. We even have a publication on it. And then I think one of the ends united, the proximal segment united better, but the distal part just didn't. And I mean, those were like my very, very initial days in Vadia. But the child was found out to be hypothyroid. So that's another thing in OI which really needs to be looked into. Non-union in OI is rare, but it is known to have other endocrine anomalies and also had some renal tubular defect. So all this talk about just giving calcium and phosphorus without, empirical, without any proper calibration, that child actually went into a very bad staghorn calculus and then a pyonephrosis, and eventually one kidney had to be removed. So, I mean, just it's a very rare thing, but I mean, if you do find time, look it up. I missed some parts of her talk, but it was definitely exhaustive.
Yeah. Okay, so now, madam, next week probably we'll have to, sit down and see the PPTs for Posicon.
Yeah, I think so. That
I
is
am in
better.
touch with
That is better.
Ankita. So this
Huh,
week, I think I will finish that off,
huh,
that
huh.
CPT one. And then,
Yeah.
next week now everybody can sit and review.
Yeah,
So
would
that
you
we
just go
still
through
have,
everyone's PPTs? That makes more sense. Correct.
yeah.
So Siley can be on hold after that. No problem.
अच्छा तो
Yeah.
Tuesday को ही करना है वो? No problem.
आप बोलो, मैं तो अभी काफी फ्री हूँ. संडे करना है तो संडे भी कर सकते हैं.
Sanika, what is the status of your PPT?
Sir, I will finish making it by this week end.
Yeah, so let's keep it next Tuesday only. Tuesday evening करते हैं फिर. चलेगा?
Yeah, yeah. कि जितने हो सके कर लेंगे, नहीं तो if necessary we do one more on the following week.
Yeah.
Yeah.
Because these 2 weeks are the only ones we have now.
Correct.
चलेगा.
Okay then. Good night.
ठीक है.
Thank you.
Okay.
Yeah.
Tomorrow's
See you all
time
tomorrow.
induction at 8. I shall be there. And,